I welcome everyone. Thank you for joining continuous learning with Bioguard. I'm pleased to introduce our webinar speaker, Dr. Everaert, a highly skilled veterinarian with over 20 years of experience. Dr. earned his Master of Veterinary Medicine from Ghent University in Belgium and has since become an expert in the care of exotic animals. He owns and operates Peripheral Vet, a leading clinic in Lubbock, Belgium, known for its cutting-edge diagnostic capabilities, including being the first one in the country to install a combined CT and in-house PCR. Dr.'s commitment to accurate diagnosis and comprehensive care is complemented by his ongoing professional development across Europe and the United States. He is also a seasoned lecturer and has authored several papers in his field. In addition to his clinical work, Dr. serves as the president of the Flemish Working Group for Exotic Veterinarians and has been the responsible vet for Everaert, Belgium's first hedgehog shelter since 2021. Today, Dr. will be presenting on how to deal with head tilt in rabbits, where he will delve into diagnostic procedures, laboratory work, and the development of effective treatment plans. Please join me in welcoming Dr. Everaert.
Hello, good day, everybody. At first, thank you for the kind introduction. As said, my presentation today will be about head tilt in rabbits. As you probably all know, it's a quite common procedure we see in rabbits. To be correct, I think it's the second most common thing we see in our practice in rabbits after dental disease. So we see it very often. So what we're going to discuss today, first I'll give a little introduction, then the different parts of the vestibular disease, so peripheral, central, or paradoxical vestibular syndrome, the diagnostics we use or can be used, the treatments and prognosis, and we will also give our workup plan, how we do it in our practice. So as said, head tilt or lateral torticollis, in English literature, it's also described as wry neck. It's a really common sign of vestibular disease. So the vestibular disease can be divided by the peripheral part or the central part. The peripheral part is the inner ear, or more in detail, the receptors in the semicircular canals or the labyrinth, and the vestibulocochlear nerve. So then the central part of the vestibular disease is located in the brainstem and cerebellum, and more in details, the vestibular nuclei in the rostral medulla of the brainstem. So a report is saying that the most common causes of the head tilt or torticollis is a combination of Otitis Media Interna and meningoencephalomyelitis by Encephalitozoon Cuniculi. So that's a really important thing to know. Those two things are most often the causes. And what really important is that they're quite often combined. So that's why it's important to diagnose and to rule out everything so that you don't think it's only otitis and it's no encephalitozoon or the other way around. So it's really important to know that it can be both at the same time. Otitis Media Interna, it's quite often a subacute to chronic onset. It's something that's going on for a longer time, and then suddenly they become sick. The Encephalitozoon Cuniculi, it's quite often that it's real sudden onset of the disease, especially after some stressful events. So you can see a flare-up of E. cuniculi, let's say after moving or going to the vet or after vaccination. Those are quite common things that happen and that can cause a flare-up of a chronic Encephalitozoon Cuniculi infection. In more detail, the E. cuniculi infection is most common cause of torticollis in small rabbits, so with straight ears, while the Otitis Media Interna is the most common cause of the head tilt in lop-eared rabbits. So the peripheral vestibular syndrome, as said, it's the middle ear and inner ear. Here is a schematic drawing of the ear of a rabbit. So you can see you have the outer ear, or the outer part of the ear with the ear canal, then the tympanic membrane with the middle ear, then and the Eustachian tube, and then the inner ear with the hammer anvil stirrup and the semicircular canals, and then the acoustic nerves going to the brain. So those parts are involved with the peripheral vestibular syndrome. So what symptoms do we typically see with peripheral vestibular disease? So yeah, that's a topic where we talk about today, of course, is the head tilt. Quite often there's also a vestibular ataxia, nystagmus, a positional strabismus, kinetosis. Kinetosis is the scientific name of motion sickness. The Horner syndrome and facial paralysis is quite common when there's like auricular diverticulosis. I will comment on that later on. Quite often, because of the auricular diverticulosis, there's a Horner syndrome because of the nervous, the seventh head nerve or the vagus is there, and it gives a paralysis. So Horner is typical. The affected side, the lip is up. So horizontal nystagmus and positional or evoked nystagmus is also quite common in peripheral vestibular disease. As you can see, there are quite a lot of symptoms combined with the head tilt quite often. So it's really scarce that it's only a head tilt. Quite often there is some strabismus, nystagmus, some Horner's disease. So to differentiate peripheral to central, it's also really important to look at other symptoms. In central disease, there's quite often a missing of there's often a dizziness too, and we will come back on that later on. So diseases that are causing peripheral disease in rabbits, it's otitis media interna with or without otitis externa. So otitis media interna with otitis externa, quite often it's the cause. It's caused because of Psoroptes, so the mite, or an auricular diverticulosis. I will come back on that also later on. But auricular diverticulosis, it's like a bulla forming in the vertical. No, in the vertical auricular canal. It's widening of the canal. There's a lot of auricular smear sitting in it. It can become infected, and then it can go deeper into the inner ear or even further. Other possibilities is an upcoming infection from the Eustachian tube, but also that I will cover later. So less common diseases with middle ear problems are middle or inner ear neoplasia. Also, cholesteatomas in the inner ear can cause peripheral vestibular disease, but it's way less common than the otitis media with or without otitis externa. So this is a common sign of the bullitis, or a middle ear infection, with most often also inner ear infection. So there's osseous involvement of the bulla. The bulla normally, as you know, is filled with air. It's becoming filled with fluids, gaseous fluids. So the problem quite often is that there's also bone involvement, and because of the fluid in the inner ear and middle ear, there's a vestibular problem. Problem in rabbits is that the pus is quite thick because they lack some carbohydrates. That's making it really difficult to drain it just by little flushing with a myringotomy. So quite often what we need to do is opening up the bulla, either with ear canal ablation, partially or totally, depending on what exactly is going on, or doing only bulla osteotomy, mainly so ventrally. But in most cases, a big part of the ear canal too is involved. So most cases it's also with total or at least partial ear canal ablation. So as said, in straight ears, mostly it's from an upper respiratory infection going to the middle ear infection causing a bullitis. It's one of the two most common causes of the bacteria are Pasteurella multocida and Bordetella bronchiseptica. But still, we really advise to do, if you do a bullitis, or even if you do only myringotomy, do antibiogram with a culture, because they are quite resistant to antibiotics. As said before, in lop-ears, there's a narrowing of the ear canal, causing a typical auricular diverticulosis. And then because there's quite a lot of pressure on the tympanic bulla, and then it's going inside and causing a bullitis. So this is typically auricular diverticulosis. This has already made open once, but the opening was not thick enough, so it closed again. So that's a good advice if you open up an auricular diverticulosis. Open it as big as possible because it's really shrinks. So some important numbers: 30% of rabbits with respiratory pasteurellosis had some subclinical otitis media on CT. So that means that even when they don't have head tilt, they already can have some kind of otitis media, making it even more difficult to get a definitive diagnosis, because it might be that the otitis media you see on CT is just there for a longer time, and it's now the Encephalitozoon Cuniculi causing the active infection, or it might be that it's indeed the otitis that's causing the head tilt at the moment. Also, some important figures: 32% of postmortem without any symptoms had some kind of otitis media, meaning that it's quite often subclinical. But then again, we don't know if they have head tilt, if it's because of the bullitis or if it's because of the other diseases. So here you see a schematic drawing of the cartilages of the ear. It's said that rabbits only have a vertical ear canal. So that's, yeah, it depends on literature, but yeah, all ear canal in rabbits is quite vertical. So normally, they don't speak about a horizontal canal, but that being said, in quite a lot of literature, you can read about the horizontal canal in rabbits. So as you can see, you have acoustic meatus with the bony acoustic meatus, and then the 3 parts cartilaginous plates. In lop-eared rabbits, there's a soft tissue between the 2nd and the 3rd cartilaginous plate. That makes the ear canal smaller, and it makes it really difficult for drainage of the cerumen. So that's why we advise in lop-eared rabbits cleaning the ears once a week with soft cleaning lotion, yeah, with some cerumen resolving lotion, because if you don't do that, as said, the cerumen needs to go up because of the lop ears. That's really difficult. So there, at the base of the ear, you can get a blockage with cerumen. So we advise from youngster rabbits doing it once a week, and we see that if you do that, the chance of getting an auricular diverticulosis is really much lower than if you don't do it. So then the central vestibular syndrome, as said, that's it's the central part, meaning the cerebellum and the cerebrum. So yeah, if you want to have all details, you can look at it. So, as said, to differentiate abnormalities between the vestibular and the peripheral vestibular and the central vestibular disease. In the central vestibular disease, what you see quite often is proprioception abnormalities. So that combined with changes in mentation, you can make a difference between the central or a peripheral disease. There can be also other central nervous system deficits with the cranial nerves, and typical vertical nystagmus. So horizontal nystagmus is quite often typical for peripheral vestibular disease. Vertical nystagmus is more common in a central vestibular disease. So the diseases that are most often causing it is a meningoencephalitis. So it can be a fungal disease. Really common, as said already, is the Encephalitozoon Cuniculi. We'll come back to that later. Other bacterial disease that can cause meningoencephalitis, also the Pasteurella, multocida, and Bordetella bronchiseptica. So Pasteurella and Bordetella can cause either peripheral vestibular disease by causing a bullitis, or a central vestibular disease by causing a meningoencephalitis. Also Listeria, Staphylococcus, Mannheimia, Hemolytica, E. coli, and Pseudomonas aeruginosa are quite often seen in meningoencephalitis. Viral disease, rabies, I can honestly say that I've never seen it, but of course it depends on which part of the world you are. There are still countries where rabies is quite common. A rabbit isn't really susceptible to it, but it can also get rabies. Also, herpes simplex can cause meningoencephalitis, also something I haven't seen yet. What I have seen, and that's quite an important differential for the meningoencephalitis, so toxoplasmosis, we have seen several rabbits with toxoplasmosis. So if you doing the differential diagnosis and you found out it's a central disease, so it's central vestibular disease, you need to do a check to see if it's either encephalitozoon or toxoplasmosis. I will come back to that in detail later, but toxoplasmosis, you can do antibodies, IgG and IgM, also possible for encephalitozoon, and for the encephalitozoon, we mainly do PCR in-house by Bioguard now, because I think that's a really advantage, having a fast diagnosis, and with in-house PCR we can have a diagnosis in something more than an hour. So that's really important, because I know quite a lot of people giving the Fenbendazole just without diagnosis and saying if they're better, probably it was encephalitozoon. The problem is you can't say that at all, because if it's a bullitis and it's getting better by the anti-inflammatory, it's not the Fenbendazole that's doing it. So, the problem too is that Fenbendazole is known to cause bone marrow suppression. It's honestly not that often, but we've already seen it. So yeah, you need to take that into account. So also other diseases in our part of the world, not common, but because everyone can join this lecture, I think it's important to know that Baylisascaris procyonis and aberrant cuterebra intracranial migration can cause meningoencephalitis. Also, lead intoxication still not very common, but yeah, you definitely need to rule it out, because lead intoxication, even in human, sometimes you see so. So other disease causing central vestibular disease, any kind of brain neoplasia. Honestly, I've maybe seen it 2 or 3 times, so not that often. Congenital meningoencephalocele, haven't seen it yet, but definitely possible. A brainstem cerebrovascular infarct. You can see, especially in really old rabbits with cardiac disease, it's definitely not that common as encephalitozoon, but it can be a cause of central disease. Also head trauma. So that's one thing you definitely need to rule out, because definitely rabbits with smaller children, it's not something the child will easily admit that the rabbit was fallen out of the arms. So that's also something you need to rule out. Some degenerative changes in the brain can cause meningoencephalitis. So that's something you need to rule out, but as said, also really not that common. So a really important one is the Encephalitozoon Cuniculi. As said, it's a fungi. To be more precise, it's a microsporadia. It's an obligate intracellular parasite, and the spores are mainly shed in the urine and bit in the feces, and they're really resistant in the environment, meaning that for up to 3 months it can survive in grass. So it's really important when you have had one that's shedding, that you need to clean very well. So as said, mainly are the spores in the urine, but also it can be in the feces. It is a zoonosis. Honestly, I've treated hundreds of rabbits with E. cuniculi. I haven't had it, but yeah, you need to say to your clients, you need to warn them that it's possible to go to humans. Also, other rodents, horses and carnivores can have Encephalitozoon Cuniculi, especially in guinea pigs or living together with rabbits. It is a differential diagnosis with head tilt, so you definitely need to rule it out. The problem indeed with encephalitozoon is that it's quite often a symptomatic infection. So just serology for IgG, that's honestly worthless, because the only thing you know is that within 1 year, the rabbit had contact with encephalitozoon. Problem is IgG lasts as long as a year. So you definitely can't say by IgG that the rabbit is having the head tilt at the moment because of the E. cuniculi. Different when you do IgM, that's going fast up and very much faster down. So if you have an IgM positive rabbit, it means that there's a positive infection. So you can have a horizontal and a vertical transmission. Vertical as said, mainly by urine, horizontal infection during pregnancy. What is really important to know, when they have a horizontal infection, the antibodies most of the time are quite low, either IgG and IgM, and the problem mainly is that it is a eye infection, mostly with causing a cataract. So they did some studies to see which kind of rabbits are more susceptible to Encephalitozoon Cuniculi. So where the antibodies of IgG were more found. So they saw that in outdoor rabbits, it's more often probably because there is a chance with contact to wild rabbits shedding it in the urine. And for some strange reason, rabbits alone or with two rabbits households are, it's more common than in multi-rabbits households. They don't have a explanation for sure for it. It might be that, yeah, a rabbit alone that's just having a little bit more stress, and that indeed in group housing that it might be with less stress, but it's not for sure at the moment why they see that they're less infected with the multi-house rabbits are less infected. So diagnosis for E. cuniculi, as said, can be tricky. Serology, IgG and IgM are, according to me, the first or maybe second step to go. Our first step definitely is the PCR on urine. You can do it on vitreous fluid too, or cerebrospinal fluid. Vitreous fluid can be really interesting when you have an eye infection, so an eye with a cataract, you can take vitreous fluid. The advantage is that for PCR, you really don't need much material. And when it's in the eye, it will be positive. Also in the urine, okay, I know it's said that it's not shed continuously, but as you all know, PCR is really sensitive. So to our knowledge, we see if they have an active infection, our PCR is positive. So if you want, you can send it to the lab for electron microscopy. Honestly, that's mostly used for research. So the microscopic examination of urine sediment, you can look at it without coloring or with a modified trichrome staining or chromotrope staining of urine. Honestly, I've read it, but I've never done it before. I think PCR is way more easy than doing that. And then taking if you want to be sure, you can take a biopsy of the liver and the kidney that has lymphomonocytic pleocytosis. In an autopsy, of course, you can see granulomatous meningoencephalitis. You can, with the liver biopsy, see a nephritis. And as said, in mainly in younger rabbits with a phacoclastic uveitis, it's quite common because of encephalitozoon. So the cuniculi serology, IgG is high from 3 to 4 weeks post-infection, and it peaks at 9 weeks, and it stays high for more than a year. So that's why it's really not helpful to rule out an active infection. IgM, that's the faster onset and also faster going down, meaning after 35 days, IgM is negative. So that means that if your IgM is positive, you know that it's an active infection. So research in different countries, they have quite different number of IgGs in just the common population of rabbits. So depending on the country, it's going from 20 to 65%. So as you can see, there are quite a lot of difference between the countries, but yeah, it's always quite high. So most of it's around 40–45%, but it can even go as high as 65%. really important thing in neurologic disease, IgG was positive in 86%, and also IgM was positive in 54.4%. So meaning neurologic disease quite often caused by encephalitozoon. As said, if you see like 54%, it means 1 on 2 neurologic disease can be caused by Encephalitozoon Cuniculi. But that's, again, the different part. Again, 24.4% of clinically healthy animals have IgM positive. So as said, it's a really pity, but still, I can't say it's like that. It will be econically on its own or econically with otitis. It's really difficult to have a certain diagnosis. You can be quite certain when you have IgM positive, but as you see here, 24% of clinically healthy rabbits are IgM positive. So still, it's not 100% sure that if you have IgM positive, it is for sure causing the head tilt. So yeah, sorry, but still it's going to, I'm not going to make it more easy because it's still a really difficult thing to diagnose and to rule out head tilt. So as said, the pathogenesis of E. cuniculi, there's a horizontal infection from the urine, can be transplacental infection, then it's going to cause a ocular encephalitozoon with a cataract. With the horizontal infection, it's mainly causing nephritis and meningoencephalitis. Then 3.9% of positive rabbits, 3.9% of rabbits are Toxoplasma gondii positive. So as you can see, it's way much lower than it is with encephalitozoon, but still in there, the IgG, it's IgG, just to know, it's still 4% of the population is infected or was infected with toxoplasmosis. It's also obligate intracellular protozoa. The phthalates are definitive host, and all warm-blooded animals can become an intermediate host, like rabbits or even guinea pigs, humans can all become an intermediate host. So another thing to rule out that's called the paradoxical vestibular syndrome, that's secondary to cerebellar or cerebrovascular infection. There's a lesion in the cerebellum, but the head tilt in this way is away from the lesion, and the fast face of the nystagmus is towards lesion. With a central vestibular syndrome, it's the other way around. So that's why it's called paradoxical vestibular syndrome. Okay, so the diagnostics. As said, Otitis Media Interna is quite common. So we always begin with X-rays. So the problem is in dogs, they already know, X-rays are only 56% accurate in dogs. So meaning golden standard is still CT. You can do, if you're really skilled with ultrasound, you can do an ultrasound of the bulla. And as said, culture of the bulla, I think it's quite important. Otoscopy to rule out external ear infections. Blood work, in an active infection, you see a raise of CRP. With E. cuniculi, you see a lowering of phosphor. And why we also want blood work is to see if they have kidney problems. So that's why the blood work is really important. As said, you can do some PCR for Bordetella, free cuniculi. That's our main goal to go to, and for Pasteurella, cuniculi, you can do the serology. Also for toxoplasmosis, you can do the serology, and urine analysis for renal failure or blood work with SDMA is also possible in rabbits. For urine analysis, you can do the urine protein creatinine. It's 0.5 is the threshold. If it's higher, then it means there's a kidney problem. So treatment, the treatment mainly of the otitis media interna with bullitis, it's myringotomy. Sometimes, most of the time, it's a PK with LBO, so partial ear canal ablation or total ear canal ablation with a lateral bulla osteotomy or sometimes a ventral bulla osteotomy. Yes, it's a quite painful procedure. We do it quite often, and if you give good pain management, they deal quite well with it. So then the medical treatment, antiemetics, the metoclopramide, we use quite often meclizine and maropitant. Domperidone is written too, but honestly, we don't use it. Prochlorperazine, that's also from the literature I got because never used it. Glucocorticoids, you can use dexamethasone, but honestly, we only do it when they have really central disease. When it's otitis, most of the time, just Meloxicam is enough. Which antibiotics you can start? Systemic antibiotics, we mainly use the doxycycline or penicillin G. Enrofloxacin can also be used, but the problem with enrofloxacin that there's quite a lot of resistance to enrofloxacin, so I would advise give it high enough, meaning 10 mg per kilogram twice daily. Chloramphenicol is also really good. The problem in Belgium is we can't get it, the chloramphenicol, but if you can get it, it's a really good thing to use in otitis. So when you do, especially when you do myringotomy, or if the membrane is already ruptured, you can do a local flush with local eardrops containing marbofloxacin, doxycycline. When you do myringotomy, you can also use earwigs impregnated with antibiotics, which you remove every 5 to 7 days. You can also use that for otitis externa without otitis interna. So same thing you can use. So then the antiparasitic for fenbendazole, selamectin and fluorolaner. Selamectin and fluorolaner are mainly used for the mites, against mites. Fenbendazole can be used against the migrating worms. And fenbendazole also works as antifungal, so it's an effective treatment for E. cuniculi if you give it 28 days at 20 mg per kilogram once a day. And also it is prophylactic. If one is shedding, you can use it as a prophylactic at the other one for 1 week. Of course, main important thing is making sure that they're still hydrated when they have a quite big head tilt and they start circling. It can be difficult to hydrate or to drink or eat. So then the daily maintenance use is 100 ml a kilogram. We mainly use the lateral ear vein. I know it's not allowed in the US. You can use the cephalic. But yes, we see sometimes partial necrosis of the ear, but still they react way less on ear vein catheterization than the leg catheterization. Assisted feeding, that's something you hear quite often. Oh my God, rabbit is not eating. Just start assisted feeding right away because it's important that the guts don't slow down. Yes, but the problem is that when there is no fecal transit anymore, it's like a balloon. The cardiac sphincter in a rabbit is really, really strong, meaning that part is closed. If the fecal transit is completely stopped, you can't add anything anymore. It's a really bad thing to go for assisted feeding when there is no fecal output anymore. So what you do then is giving painkillers, giving fluids. The moment they're defecating, then you can start by assisted feeding, but not before, because otherwise you can have a ruptured stomach. So when they are really circling, sedation can be important. We mainly use midazolam. You can go up to 2 mg per kilogram, but for us, mainly 0.5 is enough. Propentophyllin can also be used, but we haven't had the necessity to use it yet. So peak elbow was already mentioned. So prognosis. What are the risk factors of getting head tilt? One important thing is previous middle ear surgery is quite often that it can come back, either the same ear or the other ear. And previous otitis externa can cause later on otitis media or interna. So there is a higher risk for death or euthanasia with upright ears and or diminished mentation, because upright ears, as said, that's quite often otitis media interna. When there's diminished mentation, that's mainly a central vestibular disease, and of course that's less positive. So there is a residual head tilt in 66% of cases, so that's quite often. Complete recovery of the head tilt in 24%, static, so no improvement in 6%, 9% of cases end up dead, so either euthanasia or dead by themselves. And also a really important thing to know is there's a relapse of 42%. So thank you for your attention. I hope you've learned something of it. I can just, because I thought I had a slide of the way we're doing it. So the way we're doing it is first, every rabbit gets a complete clinical examination. Even if they come in for a broken leg, we still check ears, teeth, respiration, heart, everything. So then we do awake otoscopy. If we see that there's a problem with too much cerumen, we take X-rays to see if there is some problem with the inner ears. And if we're thinking about encephalitozoon, so mainly if there is big head tilt, or if there's polyuria, polydipsia, we take urine for the PCR. Treatment, we mostly do, we start with doxycycline first. If we can do a myrigotomy or Bulla osteotomy, we do antibiogram, and for the cuniculi, we use the Fenbendazole, and against the circling, most of the time we use meclozine, because that's for us the best working thing. Okay, I would like to thank you for your attention.
So the first question is, now, is there any specific breed who get mostly this problem?
Yeah, so as said, lop-eared rabbits mainly get otitis, so the head tilt by otitis. The dwarfs, dwarf rabbits mainly get encephalitozoon.
Okay, thank you. The next question is from a vet, and he is sharing a case from his clinic. So he's saying that I got 2 cases here in some clinic in Mauritius, but the rabbit having torticollis from
Yes.
last 2 years. Is
Mhm.
there any chance of recovery? I have used Fenbendazole
Yes.
at 50 mg per kg for
Yeah.
28 days, but no recovery.
Yeah. So the important thing is first to rule out why the head tilt started. So if there's it can be toxoplasmosis, definitely in Mauritius. It can be encephalitozoon. It can be E. cuniculi. So that's the first important thing to rule out. The problem with a head tilt that's going on for quite long is that there's a contraction of the muscles of the neck. So you will definitely need to do physiotherapy to loosen the neck because otherwise it's not going to cure.
Okay, so the next question is asked in Dutch language. So the question is, which ear cleaner do you recommend? And could you answer in both English and Dutch?
Yes, we mainly use AutoAct. But the thing is, you need to use something that's a really mild thing that is really good at dissolving cerumen. So which exactly you use doesn't really matter, but it's important you don't use something where there's cortisone in it or where there's an antifungal or antibiotic in it. So you just want an ear cleaner.
Okay, can you repeat this in Dutch? Because the
Yeah.
question was asked in Dutch language.
Ja, oké. Dus wij gebruiken vooral AutoAct. Op zich maakt het niet zo heel veel uit welke dat je gebruikt. Maar je mocht geen gebruiken met steroïden of antibiotica of antimicotica in, omdat je dan eigenlijk juist resistentie gaat opwekken. Terwijl dat eigenlijk, ja, het is eigenlijk, je wilt gewoon dat oorsmeer oplossen. Dus je moet eentje hebben die goed oorsmeer oplost. Oké.
Thank you so much. The next question is IgM is accurate for diagnosis or not?
Yes. So yeah, as said, yes. IgM meaning there's an active infection of E. cuniculi. As said, there are 24.4% of cases who have a IgM positive who don't have head tilt. So that's making it a little bit more complicated. But as a general rule, we say if IgM is positive, it means you have an active E. cuniculi infection when they have a head tilt. For sure, that's one of the part causing the the head tilt, but it doesn't mean that it's only E. cuniculi. It can be combined with otitis. It can be combined with toxoplasmosis. So that's a really important thing, especially when you start treatment with fenbendazole. Most of the time, in a few days, they're quite a lot better. If not, then you really need to rule out other causes.
Okay, thank you. Okay, we'll take the last question now because of the time restrictions. So the last question I'll choose is, do dwarf rabbits have a higher chance of getting a cuniculi than lob rabbits?
Yes.
Without
Yes.
looking at the otitis media in lob rabbits?
Yes, still, dwarf rabbits are more commonly infected with E. cuniculi.
Okay, over to you, Dr. Robert.
Yeah, thank you, Dieter, for the excellent and informative presentation on dealing with head tilt in rabbits. We greatly appreciate your expertise and the time you have taken to share it with us today. And thanks everyone for joining us today, and hopes to see you again in our next webinar.